Hello, everyone. Welcome, welcome. We will get started in just a moment. For those of you who are used to introducing yourselves in the chat, you may notice that the only option for using the chat at the moment is to send messages to host and panelists. That's how we're going to use the chat box today. Doesn't mean we don't want to hear from you. We'll talk in a minute about using the Q&A for questions, especially of our wonderful guest speaker today. But we do appreciate your presence and your time today. And hopefully you can join us for another activity soon, and we'll have the chat open for you to introduce. Oh, hi, Tiff. Yes, and still, someone from my team said hello just to host and panelists, which is lovely. Thank you. All right, we're getting a good amount of folks in. We are going to get started just for the sake of time. So if you're just joining us, hello and welcome. This is session 1 of our webinar series from the Connected Communities Health Initiative. We're formerly known as SDOH Academy. We have a new name this year. We're doing a webinar series around understanding and addressing the childhood chronic disease crisis. This first session, we're talking about using today's data to build a healthier future. Thanks to those who are introducing themselves to the hosts and panelists. Really quick housekeeping. Like I mentioned, we don't have the option in this particular webinar for folks to use the chat for everyone, nor are you able to come off of mute. But we hope that you'll use the Q&A box to ask any questions of myself, my colleague Danielle, or Dr. Johnson, our wonderful speaker. We are recording this session and we will make all materials available on the URL is still SDOH Academy, but on our collective group site, we'll be hosting the materials, and I believe they'll also be emailed to any of the registrants, so don't worry about not having materials. You should get those within the week. And we are going to have a brief evaluation at the end of the session. We would love to hear your feedback. It helps inform the rest of the series and other future training and technical assistance activities that we put on. All right, I mentioned at the top that we were previously known as the SDOH Academy, but there's a large group of national training and technical assistance partners known as NTAPs who have some similar goals from their HRSA funding. We're really working together through many funding years to improve health and well-being for all health center patients and their communities. We do that through a lot of different activities. This year, it's a webinar series that will be going on for quite a few more months going forward. I believe, yes, we have the purpose of the series. So when you signed up, it was a specific webinar number 1 explanation, just wanting to note that through I believe we'll have 7 sessions when all is said and done of this webinar series. All of the NTAPs that are working on this project together, our purpose is really, we're wanting this series to increase awareness of childhood chronic disease trends. So we'll talk a lot about those today, kind of laying the groundwork. We are going to mention some key drivers that were highlighted in the MAHA Children's Health Report that was put out this spring. And we're hoping that everyone's walking away from both this session and subsequent sessions being able to utilize strategies for community health management, quality improvement, integrated care, hoping to allow you to have a lot of really important insights from really educated, experienced individuals, one of whom we have in our session today. All right, real quick note, we don't have dates and times of all of the upcoming sessions as they are individual registration links. We will have a registration link to session 2 at the end of this hour, but you can see the topics that sessions 2 and 3 will focus on in this series and their dates. So we'll have one next month, and then we'll have another session in mid-February. So more information will be coming soon for sessions 4 through 7. I see a question about CEUs. Today, we're not offering any. There may be decisions otherwise in some other sessions, but it's certainly not something that the entire series was intended to provide. However, if you would like a certificate of completion for attending this session, you can definitely email us and let us know. All right, very quickly, today I'm very happy to kick us off and also have my colleague Danielle with me, who I will let introduce herself. But my name is Ariel Mather. I'm the Senior Program Manager of the National Center for Equitable Care for Elders. And Danielle, do you want to introduce yourself?
Hi, good afternoon, everybody. Thank you so much for being here. I appreciate all the hellos to us in the chat as well. But I'm Danielle Dobbins, Director at the School-Based Health Alliance, and excited to talk to you all today.
Wonderful. We're also joined by Dr. Veda Johnson, who will let these off camera still until her presentation. But she has a lot of great insights on children's health and school-based health centers. So we'll try to get through some level setting content so we can get right to her insights. Oh, sorry, Danielle. I'll let you talk a little bit about School-Based Health Alliance.
No problem. Back to me. The School-Based Health Alliance, we're a DC-based nonprofit, and we serve as the national voice for school-based healthcare. Since 1995, the School-Based Health Alliance has supported and worked to expand high-quality healthcare in schools. Our focus includes strategy, standards, data, and training to support and grow school-based healthcare, particularly school-based health centers. So we really believe that all children and adolescents deserve to thrive. Um, and school-based healthcare is a part of the solution, bringing healthcare to where students already spend the majority of their time in school. And we believe that when schools, families, students, and the community work together, students really win. We provide technical assistance and training to the school-based healthcare field. We support the improvement of students' health via school-based healthcare by supporting and creating community and school partnerships. This webinar is part of our National Training and Technical Assistance Partner Initiative, as Ariel mentioned, and it supports health center staff with the knowledge and tools they need to deliver high quality, effective care to children and adolescents.
Wonderful. The next slide has a little bit about my center, the National Center for Equitable Care for Elders. We are also a national training and technical assistance partner. We're focused on increasing the availability and quality of health center services that are tailored to the unique needs of older adults. There's a variety of ways that you can stay connected with us, lots of links on this slide. Though we focus on the opposite end of the age spectrum, as SBHA, we do believe that age-friendly healthcare benefits the whole lifespan, and there's significant value in intergenerational programming and support. And we are a part of this larger CCHI, so we're excited to partner on a topic that's a little bit different for us, but still connected. We'll quickly look at the learning objectives for this session. We're trying to, again, really lay some groundwork for us to all be on the same page about current trends and concerns in the health of children and adolescents in this country, and then hopefully also share some strategies for workflow integration, other programmatic efforts to strengthen the prevention and management of chronic conditions in our younger patients. All right, so we did mention in the overall purpose of this series that we did want to highlight some key drivers from this particular report. The Make America Healthy Again assessment is a review commissioned by executive order to examine childhood chronic disease trends. So this report synthesizes data from the CDC, NIH, peer-reviewed journals, and national health surveys. While this report does contain policy recommendations, we're not focusing on that today. We're focusing exclusively on the trends and established research findings that it documents. So these trends have been developing over the last 40, 50 years and are well documented across multiple independent research sources. But I pulled this quote because I'd like to just emphasize that this is a common goal, I think, for all of us that are here today, certainly those of us that are helping to put together this series, that all Americans can live longer, healthier lives. So there's some key components of this report. Again, because it's our first session, wanting to lay the groundwork a little bit, we can go to the next slide that gives that overview. So first, we'll again understand some of the trends, some of the health challenges. The report does identify four distinct key areas of concern: nutritional patterns, environmental exposures, physical activity and lifestyle factors, and healthcare utilization. We're going to try to briefly explore each of these areas just to give us a starting point in our conversation today. All right, so as far as trends go, according to CDC data, over 40% of children from ages 0 to 17 have at least one chronic health condition. So this is a significant increase from previous generations. We, of course, know that chronic conditions span lots of different categories: obesity, diabetes, asthma, allergies, developmental disorders, mental health challenges. What's concerning is that these trends continue to worsen each year across multiple metrics. Childhood obesity represents one of the more dramatic health shifts of the past 50 years, so rates are continuing to increase. Research shows that approximately 80% of adolescents with obesity will remain obese into adulthood, which can be connected to lifelong health challenges. 70% of youth with obesity already show at least one risk factor for cardiovascular disease during childhood. So we're seeing this as a shift when chronic disease processes begin. Diabetes trends also paint a concerning picture. Current estimates suggest that if trends continue, we'd see a 65% increase in type 1 diabetes and potentially over a 600% increase in type 2 diabetes in children by the year 2060. Another striking statistic is more than 1 in 4 teenagers now have prediabetes, these elevated blood sugar levels that put them at high risk for developing diabetes. So again, a shift from what was once considered an adult disease to a condition affecting children and adolescents at unprecedented rates. The mental health crisis among American youth has escalated, particularly over the past 15 years, especially as we started to document it differently. Teen depression rates nearly doubled between 2009 and 2019. Anxiety diagnoses and suicides have also risen in recent years, trends that represent a shift in adolescent mental well-being that requires our attention and response. So understanding these trends is essential. We'll continue to talk about some of these trends in our session today, but what really matters most is what we're doing with this knowledge. Health centers are uniquely positioned to address these challenges because you serve patients across the lifespan and have deep connections to community resources. But let's focus just a little bit on those key factors for a little more level setting. For nutrition, nearly 70% of children's calories these days come from ultra-processed foods. So these are foods that undergo extensive industrial processing, contain ingredients that you probably wouldn't find in a home kitchen. Certainly 100 years ago, essentially 0% of calories came from ultra-processed foods. This really means we've undergone a complete transformation of the American diet within just a few generations. So we know that ultra-processed foods are characterized by high levels of added sugars, refined grains, industrial fats, numerous chemical additives. So these are, designed for convenience. They have a long shelf life. We know kind of lack the fiber, vitamins, minerals, other nutrients that whole foods can provide. There's a lot of links between ultra-processed food consumption and various adverse health outcomes, whether that's cardiovascular disease, type 2 diabetes, mental health disorders. So as the consumption of ultra-processed food has increased, whole food consumption has declined. It's estimated that over half of children and adolescents don't eat a discrete fruit on a given day, similar to rates with vegetables. Research consistently shows that diets that centered on whole foods are associated with lower levels of a lot of these chronic conditions that we've mentioned. This shift away from these whole foods represents really a loss of nutritional quality that can affect the entire body system. When it comes to environmental exposures, there's over 40,000 chemicals that are registered for use in the United States, I think even more than that. And research has detected pesticides, microplastics, industrial chemicals in the blood and urine of children and pregnant women. Children are particularly vulnerable to chemical exposures. There's a few critical developmental windows in utero, infancy, early childhood, puberty. What's challenging is that current risk assessment methods typically evaluate one chemical at a time, but children are exposed to complex mixtures of chemicals simultaneously. So research suggests that these cumulative exposures may interact in ways we don't fully understand, potentially contributing to chronic disease development. but we lack the long-term studies on how multiple chemical exposures interact over time, especially during critical developmental periods. The challenge is by the time we have definitive proof of harm, generations of children may have already been exposed. This creates a tension between the precautionary principle and the practical realities of modern life. For physical activity, we know that a good portion of children and teens fail to meet the federal guideline of 60 minutes of moderate to vigorous physical activity per day. This decline has a lot of reasons, not just screen time, but safety concerns, reduced physical education in schools. The health consequences we know are significant. Physical activity plays such a crucial role in bone development, cardiovascular fitness, metabolic health, mental well-being. So the decline in fitness levels has been pretty well documented, measurable decreases in aerobic capacity compared to previous generations. Um, Physical activity decline has, been coupled with a dramatic increase in screen time, though. Lots of statistics about the number of hours a day that teens are on screens, not including the hours they're on for educational purposes. This impacts things like sleep quality, the amount of sleep that folks are getting. Um, and beyond the physical effects of inactivity, we're seeing real changes in how children connect socially. This matters because social connection is such a fundamental human need. With measurable health impacts. Loneliness and social isolation are associated with increased risk for a bunch of things, mental health, physical health challenges. That's something I focus a lot about on the other end of the age spectrum. The shift from in-person play to screen-mediated connection really represents a fundamental shift in child development that we're really just starting to understand. And finally, just our last factor that was described in the report, as chronic diseases have increased, so has medication use in children. Medications can certainly be life-saving and appropriate. There are patterns that this report and others have started to note in maybe some concerns of how they're being prescribed. Certainly with the changes in how things are documented, prescriptions for ADHD and antidepressant prescriptions in teens have increased significantly over the past few decades. Even though these medications are safe and usually effective, they might not be the only recourse. Psychotherapy is a great tool that can be incorporated into a treatment regimen. Antibiotic overuse in children presents another concerning pattern. Research indicates about 35% perhaps of childhood antibiotic prescriptions are unnecessary. So this is a concern not just for antibiotic resistance, but there's a stronger connection of children developing asthma, allergies, celiac disease, obesity, ADHD. All of these findings, I know this was a really rapid fire overview, these findings suggest that our healthcare system's response to the rising childhood challenges may in some cases be creating additional challenges, additional problems rather than addressing root causes, which I know that our speaker today will be talking about quite a bit. We, of course, know there's other factors that influence children's health, so I'm going to turn it over to my colleague Danielle on the next slide to talk about a lot of these factors that intersect with the work that health centers do.
Thanks, Ariel. Now, as we think about how health centers can best serve children and adolescents, it's important to remember that their needs are multifaceted. We're not just talking about medical care, but the full range of factors that influence a child's ability to learn, to grow, and to stay healthy. When we say health-related needs, we mean those non-medical factors, things like food security, stable housing, family support, safety, and their ability to pursue opportunities. All of these have a major impact on health outcomes and educational success. So recognizing these factors allows us to go beyond treating illness and to really strengthen the connection between health centers, care delivery, families, schools, and other community partners. So for the role of health centers, as we continue the conversation about the growing crisis of childhood chronic disease, it's important that we pause and center our attention on the critical role that health centers play in responding to this challenge. Health centers aren't just a part of the solution. They are often the foundation of community health for children and families. First and foremost, health centers are gateways to quality care. They provide services for children and families who might otherwise face significant barriers. Those non-clinical factors of health, whether it's cost, transportation, or even availability of providers. In many communities, the health center is the first and most consistent point of contact for healthcare services. That reliability builds trust and continuity, especially for families navigating complex chronic conditions with their children. So let's talk a little bit about the reach of health centers. As we think about the incredible work that health centers are doing to support children and families, it's important to take a step back and look at the national reach. Health centers are not small or isolated efforts, they are vast interconnected networks that touch nearly every corner of our country. Health centers operate in every US state, the District of Columbia, US territories. This national footprint means that no matter where a child lives, whether in a rural community or a dense urban neighborhood or a territory, there's a good chance that a health center is there providing care. So collectively, health centers serve more than 32 million patients across the nation, including more than 9 million children. Next, we'll take a look at the impact of this reach. So health centers are uniquely positioned to support health across the lifespan. We talked a little bit about that earlier, and they are there for every single stage, for every childhood screening and preventative visit through adolescence and often into adulthood. That continuity means health centers can identify risk factors early, they can intervene sooner, and they can manage conditions over time. It's about building a foundation for lifelong health that starts early and adapts as children grow. So as we move through today's session, I invite you to keep this framework in mind. Health centers are not just providers of care, they are really catalysts for community health transformation. The role, the reach, impact, relationships, and innovations are essential in shaping a healthier future for all of our children. So now that we've explored the vital role, reach, and impact health centers play in addressing the growing crisis of childhood chronic disease, we'll move into a conversation with someone who has been leading this work in practice. It's really my pleasure to introduce Dr. Vita Johnson, professor in the Department of Pediatrics at Emory University School of Medicine and a nationally recognized leader in school-based and community health. Dr. Johnson will take us deeper into the real-world impacts of these concepts, examining the magnitude of the child health crisis and sharing how comprehensive community-centered approaches can build stronger, healthier children. Her work highlights both the challenges and the opportunities before us, from understanding the scope of chronic disease in children to advancing strategies that strengthen families, schools, and communities together. So with that, I'll turn it over to you, Dr. Johnson. Thank you.
Well, thank you. Thank you for the introduction, and thank you for inviting me to share to giving me the opportunity to share my thoughts on the health and well-being of our children. I never shy away from the opportunity to speak on behalf of the work that the School-Based Health Alliance is doing and what the community health centers are doing throughout this country. I guess I'll just start. Next slide, please. We've already talked about the declining health of children. We've already talked about the data um, that is really startling, to tell you the truth. I mean, we can look to, for those of us who've been doing this work for many, many years, we have witnessed a significant decline, but I guess when the data actually was revealed, especially in a study that was distributed this past summer, that we began to understand the state that we were in, and it was really disconcerting. In the JAMA study that was released this past summer, they looked at the declining rate of health for our children between, I think, 2007 and 2023. And they saw that there was this significant rise in chronic conditions with the prevalence of chronic issues between 26 to 30% in children aged 3 to 17. And especially in these categories of asthma, obesity, the neurodevelopmental disorders such as autism and ADHD. As we already have stated, the mental, emotional, and behavioral health disorders of children have skyrocketed, especially since COVID, and substance use disorder. And this particular study, which was probably the most distressing, demonstrated that US children were twice as likely to die than children from other economically advantaged communities or countries throughout the world. And so, you know, again, we have witnessed firsthand the challenges before us. But, you know, even for someone such as myself who has been doing this work for over 40 years, I didn't realize the magnitude of it. We also know that children who live in poverty are at greater risk. They're much greater risk for poor and declining health. And the statistics for children living in our country is dismal. We know that approximately 12 million of our children come from economically disadvantaged households. The U.S. ranks at the bottom of children who live in impoverished communities. And we know as a result of this, these children are also at much higher risk for health problems, mortality, increased risk for academic underachievement, school dropout, unemployment, and all of the factors that impact their ability to maximize their potential. Next slide, please. So we're living in troubling times. We really are, and we need to acknowledge that concerning the health and well-being of our children. And you know, for those of us who care for children, we may feel a little bit cast down, but we are not in despair. We acknowledge the work before us, and we are more than willing, and we're more than able as a country to reverse this downward trend. And why is this important? But this is a paraphrase quote from Frederick Douglass, which is my guiding principle. This is why I do what I do, which says it's easier to to build strong children than to repair broken men. You have to excuse me. I tell people I'm still in another time zone, but it is much easier to build strong children than to repair broken men, and that should be our aim as we create a system of support for the children in this country. Next slide, please. So what does it take to build strong children? Well, it really starts with the family. And I know we haven't mentioned that yet, but that's probably the most critical piece in all of this. This whole parent-child dyad is critical when it comes to building strong children, validating, nurturing children, exposing them to early childhood brain development and maximizing school readiness. All of that is critically important to building strong children. But then the other support systems that comes from our community, that comes from our country, are equally as important. And I'll get into that a little bit. We need to create a framework, as we've already said, for good health and a framework for academic success early. We know that poverty is the single greatest threat to a child's well-being, but we know also that education is a pathway out of poverty. So good health and educational achievement go hand in hand when it comes to lending itself to maximizing potential for children. We need to identify deficits in children very, very early, and that's before they actually enter school. And we need to intervene aggressively and monitor thoroughly as we are following these children. We need to champion. And I hope that this talk will motivate us as we listen to these statistics and listen to the condition that we find our children in to serve as champions for our children, not only for the health, the physical health of our children and the educational achievement for our children, but also for safe and supportive communities, for leadership development, for supports for families who are also struggling in these really, really critical times. Next slide. I always like to point to America's Promise because it really does sort of set the framework of how we build strong children. America's Promise was created in the late 1990s when all of the living presidents came together for a two-day summit to determine what was required in order for children to achieve the promise of America, the promise of happiness, the promise of self-fulfillment, the promise of self-sufficiency. And they came up with 5 promises. And the first was a caring adult. And these are all sort of intuitive because all of us have been working on this even before this sort of structure came into being. It includes a healthy start, or just basically what we're trying to define right now, an effective education, safe places, and I can have a complete talk on safe places, and the opportunity to help others. And so those are the 5 promises, and that's really the impetus behind how we approach addressing the needs of children through the work that we do. Next slide, please. So I was asked to talk about school-based health programs as a means to address the challenges that we're finding our children in at this current state. How do school health programs raise strong children? Well, we do it through the intersect between good health and academic success. But let me just say a little bit about the root causes of all of the challenges that we find our children in. Well, it's again intuitive and quite simple. You know, the reason that our healthcare system is the way that it is, not only for our children but for our country as a whole, is because we have a real challenge with access to quality healthcare. And all of the great work that community health centers are doing and school-based health are doing, and a lot of other health systems are doing, it, to a certain extent, are not it's not quite enough, right? And so we really need to expand upon the access to quality health care in this country. And we need to understand that in order to have quality health care in this country, people have to be able to afford the health care. They need to be insured. They need to have providers who accept their insurance and are sensitive to the needs of the people. So access to healthcare is critically important when we're talking about determining the root causes of the downward trend of health in our children. The other really important aspect of this, especially since we're talking about food, is access to healthy foods. We talk about how children are really consuming the wrong types of food. A lot of that has to do with the fact that they don't have access to healthy foods. The fact that they live in what we used to call food deserts, which now we call food swamps, and that a lot of our families don't have the financial ability to purchase healthy foods. So we need to address those core issues, and there are a lot more core issues before we can talk about reversing this downward trend. But one of the solutions for me, as I've been practicing this for over 30 years, is school-based health centers. Because school-based health centers do increase access to quality health care. And they do also galvanize the community around the needs of the children, not just for their health care, but for all of the factors that contribute to this downward trend. Next slide, please. So what are school-based health centers? This is an old definition, but I think it really does capture the essence of school-based health centers. They say they're comprehensive medical centers that blend medical care with preventive, is what we've been talking about, and psychosocial services, as well as organize broader school-based and community-based health promotion efforts. That's in essence what we're talking about in this particular talk about what does it actually take in order to improve the health and well-being of children. What does it take to reverse this downward trend that we find ourselves in? It means bringing the entire community together to address not only the physical health of a child, but also the psychosocial needs of a child, and also the prevention and to prevent a lot of these conditions from happening to begin with. But it takes the entire community and not just a healthcare entity. Next slide, please. These are the 7 basic principles of school-based health centers. First, they support the school, not only the students, but everyone who cares for the child and who tries to provide the services in terms of the educational instruction. They respond to the community because there's community engagement, and I'll give you an example of how we have galvanized communities around the development of these centers. They focus on the student, they deliver comprehensive care, they advance health promotion, they implement effective systems that support the entire child, the community, and the school, and they provide leadership in adolescent and child health. These are old principles, but they're really apropos for the day. Next. So we've been studying school-based health centers for over 40, 50 years, and the outcomes have demonstrated that, you know, they really do increase access to quality health care. And the research continues, and it's much more convincing, even as I review some of the papers that have come out lately. It improves health outcomes, especially for children with chronic diseases such as asthma and also obesity. I actually did a study many years ago to demonstrate that the work we were doing through the school-based health centers reduce obesity and also the risk, the sequelae of obesity. It improves school attendance and seat time and academic performance, especially for those children who have social and emotional challenges. And we have demonstrated in multiple studies that it decreases healthcare costs. Next slide, please. So what does it take to develop a school-based health center? Well, first, it is school-based health. We always say if you've seen one school-based health center, you've seen one, because they reflect the community in which they're created. And in order to actually effectively strategize around how you develop these centers, you have to start with the community. You have to get the buy-in from the community and let them take the lead in developing these centers. So you have to recognize community need and definitely get their support in order to do it. You have to create a model that you know is going to be sustainable, because historically, a lot of our school-based health centers were just funded by grants. And once the grants were exhausted, a lot of the school-based health centers had to close. And so you have to come up with a sustainable model. And I can go into a little more detail about that. You can demonstrate that what you're doing is of value. The evidence of health and cost impact have to be an integral part of what you do in order to support and expand these centers. And I throw in this fidelity to a model programs, because you have to find a model that works and then replicate that in order to effectively expand these centers. And so with the work that we've been doing in the state of Georgia, we started with 2 school-based health centers about 30 years ago, and they were the centers that I created. And for about 18 years, we were the only 2 school-based health centers in the state. And it was such an exceptional model. You know, as a pediatrician, I've worked in every model of healthcare you could think of. I've worked in federally qualified health centers. I worked in hospital-based models. I worked with private practice. But once I started this work within a school-based health center, did I realize that this was the best model of healthcare for children who live in under-resourced communities. And the fact that we had only 2 school-based health centers in our state for over, 17, 18 years just didn't sit well with me. And so I set about taking this model to scale. And so I took these 4 basic elements and I sort of confine them to 3 basic strategies. The first is a planning strategy where you actually galvanize the community around the need for a school-based health center and the healthcare needs of its children. The second is that you find a way to implement it in an effective way that can lead to sustainability. And so the 3 phases that we've been working with over the past 16 years have been the planning phase, implementation, and sustainability phase. Next slide, please. So the planning phase really talks about community. It's about galvanizing the community around the needs of its children. The state of Georgia has 159 counties, more counties, only second to Texas that has 166 counties. So I have a lot of counties to work with. And I have worked with probably over 100 of those counties over the past 16 years. And one thing that is really striking and really rewarding is that every county loves its children. Every county is really invested in the well-being of every child in their community. And it doesn't matter if they're like in the northern part of the state or the southern part of the state, or in the rural areas or in the urban areas, everybody cares for their children. But oftentimes they don't know how to come together to identify and address the needs of their children. And so we have been awarding planning grants over the past 16 years to these individual counties to bring all the stakeholders together to first identify the needs of their children and to come up with strategies to address the needs of their children. It has increased public will and knowledge around the needs of their children, but also around the merits of the school-based health center program. And we do that through community forums, through surveys, through focus groups, through training, through technical assistance. And we work with these counties for over a year in order to complete the process. Again, there are 12-month planning grants. We can Okay, something came up front. We create a community advisory group to begin with. Like I said, that consists of all the stakeholders in the community. We conduct formal needs assessment and define strategies to address the needs, and we develop a business plan throughout the course of that year. I usually bring them up to Atlanta to the university for workshops. I meet with them every month to provide technical assistance and guidance. And at the end of those 12 months, it is amazing. It's a transformation in that community around stakeholders coming together to address the needs of their children. Next phase, please. Next slide. Like I said, I've awarded about I actually awarded about 71. We've recently awarded 3 more counties this past grant cycle, 71 planning grants that represent about 75 counties in the past year, but I've worked with about over 100 of those counties. We've increased access to healthcare. We've increased the number of school-based health centers as a result of these planning grants from 2 to over 145, really it's about 150. We estimate that about 90,000 students have increased access to healthcare, but it's really probably closer to about 120,000 students. And that's just the students. That's not their siblings or other children in the community. And many of our school-based health centers actually provide services to the entire community. We focus on the physical, the mental, oral, and the vision of these children. Vast majority of them are in our rural parts of the state. Over 80% of them provide on-site behavioral health services, but all of them screen for health risk, behavioral health risk. Say that again, behavioral health risk factors. And many, and even if they're not on site, they provide services through telehealth and through connections with local community providers. About 10% provide on-site dental services, and we have two comprehensive vision centers that serve the entire school district that are located in the state. Next slide, please. This is a map of our planning grants. These are, it's not up to date because we've added 3 more, but as you said, we have covered at least over half of the state, and we're just really thrilled that this has been an outcome. When we started out 16 years ago, we never anticipated that we would have this much buy-in and this much success, but it is about community coming together, and that's probably the most critical piece of all of this, community coming together to understand and recognize and work toward improving the health and well-being of their children. And if we are going to address the downward trend that we see in the health of our children, it has to be community-based, community-led. And that's where community health centers come in. They can do very similar work to what we're doing in school-based health centers, and other health providers, the local hospitals, and especially the children's hospitals, and some of the other medical institutions can come to the academic institutions can come together to create this system of support and to connect with community to do this work. Next slide, please. These are the numbers of school-based health centers that we currently have as a result of our planning grants and as a result of a lot of the work that we've been doing apart from the planning grants. I want to say, take the moment to acknowledge our governor, who, after a lot of testifying and advocacy in our state capital, allocated $125 million to our state to expand school-based health centers 4 years ago. It was unprecedented. No one has ever allocated that amount of money to expand school-based health centers, but it spoke entirely to the success that we've had in mobilizing community and getting the advocacy from our local legislators as well as community members to acknowledge the value of these centers. Next slide, please. So when we're talking about how we provide quality care in our school-based health centers, we have come up alongside the National School-Based Health Alliance performance measures, which are very similar to what you would find in a regular pediatric practice. But we find that for a lot of these performance measures, school-based health centers can be a little bit more effective, especially in managing chronic illnesses and also in doing preventative services than some of our counterparts, and mainly because we have access to children. It's not because that we're more skilled or we have more knowledge, it's because we have more consistent access to these children. And so as we've come up with performance measures, we have been able to demonstrate that not only do we increase access to healthcare, but that we also contribute to the overall health and well-being of children, and that the more school-based health centers that we have, as far as I'm concerned, the greater possibility that we'll be able to impact this decline that we're seeing in the health status of our children. And so our performance measures have to do with preventative services such as well-child visits and immunizations and screenings. We do a ton of risk assessments, especially based on age and especially around depression and anxiety. We have great measures for asthma management and obesity management. We look a lot at the impact that school-based health centers have on seat time and attendance and on academic achievement. I'm convinced that the work that I do is critical to increasing access to healthcare, but I think more importantly, the work that I do is about how do you maximize the academic achievement for children, especially between the interface between health and education. And then there are other metrics that are part of our performance measures. Next slide, please. So for the 100 plus school-based health centers that I have helped to create over the past 16 years, I've insisted that they actually captured the data based on the work and performance measures that they do. And it's critically important because, you use this data, first of all, to demonstrate the value of what you're doing. Remember, I was saying one of the critical pieces of expanding school-based health centers is that you can demonstrate the value of what you're doing. But you also use it as a quality improvement tool, right? So if you capture your data and you haven't reached the benchmarks that you have set for yourself, then you try to figure out a way to improve upon the delivery of your services so that you can reach your quality metrics. And again, what people want to see, the data that people want to see is not only how to have you improve the health and well-being of these children and access to healthcare, but how has it impacted their ability to be in school and to learn. I always say, children, everyone knows this, children learn best when they're present, children learn best when they're healthy, children learn best when they're connected, socially and emotionally connected to school, and children learn best when they actually have hope and have the will to learn. And we have demonstrated that school-based health centers can contribute to all of those factors that improve not only the health, but the educational achievement for children. Next slide, please. This is an example of a template that we've created to capture the data for our quality metrics and our benchmarks. And we have about 6 of these templates. And this is an example I just wanted to show you. And I can send you this template if you're interested in it. But our very first one really captures the enrollment and utilization of our school-based health centers, because if children are enrolled and they're not utilizing the center, then we really can't provide the care that they need and impact their overall well-being and their educational achievement. So this is about enrollment and utilization. We've divided it based on the services that you provide, whether you provide medical services or mental health services or dental services, and we also have one for vision. And we monitor this every month to just see if we are increasing the number of children who are enrolled and actually utilizing the center. Next slide. This is another template on asthma measures and really follows the recommendations that we as pediatricians use to monitor and manage asthma in our private offices. So it's no different from that. I think it's critically important because with my very first study, the reason I actually did my very first study, which was over 25 years ago, is that I realized that I could identify and manage children with acute and with moderate and chronic asthma better than I could in my school-based health center than I could in my office, my private office. And the reason is it has to do with access. I had access to these children. And so if I needed to see them, say in a week or two because they had an exacerbation, all I had to do was pull them out of class. If I see in my private office or my hospital-based office, then it was up to the parent to bring them back to me in a week or two or a month in order for me to monitor them. And oftentimes my parents could not bring the children back. They did not come back. But when I started managing these children in the school, I realized all I had to do was just call up to the classroom and pull them out and manage and see how they were doing and monitor how they were doing and talk to their parents on a regular basis. And so I conducted my very first study about 25 years ago to see what was the impact of the school-based health center on improving asthma outcomes. And it was just startling. I mean, it was much more significant than I ever thought it would be. And the cost of the Medicaid system was literally cut in half for children with asthma because of the decreased emergency room use and the decreased hospitalization for those children. And so these measures really are very similar to what you would see in a private doctor's office, but would help you monitor just how well you were doing. And when you find that you're not seeing the children back as often as you should, then you create a strategy, working with the school, working with the parents in order to make sure these children come in for their follow-up. Next slide, please. Oh, so I thought I had other templates, but I have several others. I have one on obesity. I have a template on well-child visits. I have a template on mental health services as well. And if anyone's interested in any of these templates, please do not hesitate to contact me. And so I'll stop here. I was going to go on and on, but I'll stop here. So if there are any questions.
Dr. Johnson, thank you so much for all you continue to do to build strong children. Thank you to everyone that has joined us this afternoon. That was a great presentation. So at this time, as Dr. Johnson mentioned, we'd like to address some of your questions. So please use the Q&A feature or the chat to send your questions to us. Thank you. See some comments about great presentation. Appreciate that.
And we have a few folks that are saying yes, they want to see all the templates. So we'll work
Mhm.
with Dr. Johnson to figure out the best way to make, any of those resources available to folks, whether it's a direct email to request things or, if there's some we're able to send to all registrants, we'll figure that out for sure. Yes, folks are interested. That's great. While folks are maybe thinking of some other questions, Dr. Johnson. I am curious just because like I mentioned at the beginning, my center is focused on the other end of the age spectrum. So a lot of my work is focused um, on older patients, but also just the intergenerational connections and the health across the lifespan. And you mentioned in one of your early slides around strengthening the parent-child dyad and other support systems. Is there anything else you want to give us, just insights on, a lot of the, concerning behaviors we were talking about? They don't exist in isolation. Obviously there's so many different factors there, but thinking about the different family systems that children might find themselves in. Any reflections on family engagement, on community engagement when it comes to improving health behaviors in children?
Absolutely. So in order to effectively improve the health and well-being of children, you have to do it in the context of the whole child, right? And you can't care for a child in isolation or in a vacuum. And you have to understand the factors that contribute to the health and well-being of children. And that's one of the reasons that I really love school-based health centers, because you can actually see firsthand all of the factors that impact the life and well-being of a child, which is something completely different from what I witnessed when parents bring their children to me. They only show me the side that they want me to see. But in school-based health, you get to see, I always say, three-dimensionally, right? So you get to see the child's interaction with their family. You get to see their interaction within their community, within their school, and with one another. But more importantly, you see that interaction between the child and the family. And that still is the same approach, even in my hospital-based practice that I take in order to address the needs of the children. We know this whole two-generational connection between children and their parent and their caregiver is critical, right? And you really can't effectively address the needs of the children without understanding the needs of the family. And so one of the things that we do in our practice is that we have a family resource survey that we give to all of our families when they come in to understand the challenges and the risks that they have, knowing that all of those challenges impact the health and well-being of children. And we have created a system that supports not only the child, but the family as well. And again, as I think Danielle was talking about, those factors, it goes beyond the health, it goes toward, whether you have stable housing, whether you are food secure, whether there is some emotional, psychosocial issues around for the mother or the father, the caregiver, whether there's domestic violence, all of those things that are critical in addressing the needs of the children, you have to take in consideration for the child when you're caring for them. So our approach has always been the whole child primarily as the interface between the child and their family and their community, but more importantly, what are the needs of the family as a whole? Because we realize that all of those factors impact the lives of children.
Thank you. As you all continue to type your questions, I also encourage each of you to complete the evaluation for today's session. We'll drop that in the chat, but it really helps us develop content that supports you in all the work that you're doing. Thank you, Ariel. We did have another question that came in, Dr. Johnson. To fund these centers, what have you found to be some of the most successful avenues?
Say it again.
To
Can you
fund
repeat
these
that?
centers, what have you found to
Funding?
be what have you
Oh,
found to be some of the most successful avenues? I think maybe the person was referring to school-based health centers.
okay. Initially, it was philanthropy.
Mhm.
And I'm sure for a lot of our communities, philanthropy plays a really important part. But for us, it definitely was philanthropy. And it continues to be. And then there were some, and I'm not quite sure what this year's budget is, but there've been sort of consistent funding nationally for school-based health centers. They've primarily gone to federally qualified health centers, but at least there's been a line item budget about 50 million for school-based health center expansion from the federal government. There are several states where school-based health centers are funded through their state legislature, and those are, one of those, ideal kind of states to be in. And that's why when we received $125 million from the governor, we were just, you know, thrilled beyond belief. I can't begin to tell you how thrilled we were for that. Even though those dollars have gone away, we're still sort of advocating on the state level. Um, Sometimes hospital systems step in and do a really good job. We have several of our school-based health centers that have been funded by foundations from hospitals. Some of the major companies in your community, you just have to present the case for how important it is for parents who are employed by some of these companies to stay at work, and it'd be to their benefit to contribute to creating this system of care for these children and their families, so their parents can stay at work. And there are many avenues, and it's not just one that is sort of the panacea. I do find that some of my federally qualified health centers find a way to fund their centers through their internal budget. That has been pretty significant in this state, and surprising to me. I may have funded, two or three of them, and then next thing I know, they've opened three or four more on their own. And so, they find the dollars because they realize that once they get into schools and they can bill for their services and get enhanced Medicaid reimbursement, then they can actually sustain themselves. So it is a combination of funding sources, but I think philanthropy is always present to do startup. And we always say if you can fund us for 3 years and we can enroll enough children and have them utilize the center and have them connected with something like an FQHC who get enhanced Medicaid reimbursement, then they can sustain themselves. But we still look to the federal government, hoping that they will continue funding, having, school-based health centers in the line item within the federal budget, and states. Yeah.
Thank you. I think we may have time for just one more question. So I'm sorry we didn't get to everybody. But Dr. Johnson, do any of the school-based health centers employ CHWs to link with community and family?
Yes. Yes. And I find it probably be the most effective way to actually do this. If you have the funding to do it. I mean, I've been advocating for, to have, community health workers. Is that what you're saying? The CHC's community health workers? Yeah. Serve as that liaison between the families and the school-based health centers and the family and the school, which I find that they, once it's interesting for me how families perceive the school-based health centers as opposed to the school itself, even though the school-based health center is inside the school, right? I found that parents will come into the school-based health center before they're coming to the school to see a teacher or a counselor or administrator, right? Because I see it as a neutral place, right? They don't see us as blaming them for whatever's going on with their children. Their perception of teachers and counselors, especially when their children are not doing well, that they perceive that, a lot of it stems from their home, and they feel, and they really get their backs up behind that. And so they are reluctant to come in and to talk to teachers and counselors, but they'll come in to the school-based health centers and share everything with us. And so we also can serve as that liaison between the parent and the teachers and the counselors and the school administration. But having a CHC to serve in that capacity is I can't tell you how critical that is and how much of an advantage that is in order to make those connections and to continue to have those discussions and that communication that's really critical to having a successful school-based health center. I always say that, in order to really do this work well, you have to fully integrate the school-based health center into the fabric and the fabric of the school. And so to have someone to serve as that link is critically important.
All right, amazing. Thank you again, Dr. Johnson, for your time and your insights. I know that this group really appreciated it. Lots of folks putting thank yous in the Q&A, which is great. I did just put a link in the chat to promote our second session. Juliet, you can go to that. Yeah, please do fill out the evaluation as well. I know we put that in the chat earlier. I believe it'll also pop up when you close out of this window. but we really value your feedback. And on the final slide, I believe we have the date and time announcement and the title of our second session in this series. So some of our other wonderful NTAP friends are going to be focused on early detection and prevention using community context and dietary screenings. It's going to be next month on December 9th. There was a bit.ly link that the Zoom chat didn't like, so there's a much longer one in the chat. And I believe we'll also be sending reminders out via email, both to this group of registrants and if others that have attended S2H Academy activities previously. We thank you all for your time today. We know that it's precious, and we really appreciate your attention and your energy and your participation. We hope we'll see you at a future session of this series, and take good care. And thanks again, Dr. Johnson, for all of your wonderful insights.
My pleasure.
Thank you, everyone. Take good
All
care.
right. Bye-bye.